If you've just been told you need a cancer screening, you are likely facing a deeply frustrating question. Why go through a painful, invasive surgical biopsy if doctors can now look for cancer using a simple, pain-free blood draw? The reality is, neither test is inherently better than the other. They are entirely different tools designed for completely different phases of your treatment. A tissue biopsy physically extracts a piece of the tumor. Doctors need this solid sample to examine the actual cellular architecture and grading under a microscope. A liquid biopsy searches your bloodstream for genetic breadcrumbs. As cancer cells break down, they release tiny fragments of circulating tumor DNA, or ctDNA, into your blood. Looking at this comparison, on the left we have the blueprint, on the right, the radar. The blueprint provides your oncologist with absolute structural certainty of what the disease actually is. The radar tracks the unseen genetic signals that disease leaves behind. Once you understand exactly when your doctor needs the blueprint and when they need the radar, a terrifying medical ordeal becomes a logical, predictable sequence. This timeline charts the patient journey, starting here at the initial diagnosis phase. Right now, the absolute priority is structural certainty. To get that certainty, doctors must rely on an invasive core needle extraction or perform a minor surgery. This yields 100% accurate architectural data, allowing pathologists to confirm the exact type of cancer you have, like distinguishing an adenocarcinoma from a squamous cell carcinoma. Because it requires physical extraction, you will need recovery time. There are minor infection risks, and the procedure can cause significant discomfort, especially if the tumor is deeply embedded in the lungs or the brain. You might ask why we can't skip the surgery and use a liquid biopsy here. The problem lies in early-stage detection. If you have a stage 1 or stage 2 cancer, the tumor may not be shedding enough ctDNA into your blood yet. A liquid biopsy could report no cancer at all, even when a tumor is physically growing in your body. But look at what happens when the disease advances. This graphic shows a primary mass and distant spread, releasing tiny genetic fragments into the bloodstream. Notice the different colors. As cancer spreads across the body, it develops distinct different mutations in different areas, a phenomenon known as tumor heterogeneity. A surgical needle can only pierce and analyze one isolated location. A single liquid biopsy captures this entire diverse genetic profile at the exact same time. You are mapping the entire systemic footprint of the disease through a single needle stick in your arm. You have to endure the physical biopsy to accurately name your enemy, but you rely on the liquid biopsy to understand its true scale. Moving forward on our timeline, we reach active treatment. By this point, patients are often physically exhausted from ongoing hospital procedures. Here, doctors substitute further surgeries with recurring pain-free blood tests during chemotherapy or radiation cycles. This monitors your blood in real time. If ctDNA levels drop, the tumor is shrinking. If those levels rise, the cancer is becoming resistant. Processing these advanced sequencing reports takes 7 to 14 days. It requires more patience than your standard next-day lab work, but the data dictates your next move. Doctors use that data for course correction. Over time, a tumor often genetically mutates to survive the chemotherapy drugs actively attacking it. When that happens, the original tissue sample sitting in the pathology lab is completely outdated. The cancer you have today is genetically different from the cancer you had at diagnosis. Instead of subjecting a weakened patient to a second surgical biopsy, doctors use the blood to identify those new genetic mutations, like EGFR or ALK. Finding those specific markers allows your oncology team to instantly pivot your treatment onto highly precise targeted therapies. During active treatment, a liquid biopsy operates as a real-time feedback loop. It saves you from repetitive surgical trauma while ensuring your drug regimen remains aggressively up to date. Eventually, you reach the remission phase. Treatment is over, but the psychological burden takes hold, the constant underlying fear that the cancer might return. This introduces minimal residual disease, or MRD. These are the absolute earliest molecular traces of returning cancer cells. Liquid biopsies can detect these microscopic traces months before physical tumors ever trigger symptoms or appear on standard CT scans. Look at this checklist to map your diagnostic journey. Which test do you need today? If you are a first-time patient facing an initial diagnosis, a tissue biopsy is non-negotiable to confirm your physical blueprint. If you are currently undergoing active treatment, ask your doctor about a liquid biopsy to track your drug's efficacy without additional pain. And if you are cancer-free and in remission, the liquid biopsy is your proactive early warning radar for minimal residual disease. Remember the core rule: these two tests are never competing against each other. They are strictly complementary partners in modern oncology. Trust the sequencing of your doctor's orders. Expect the tissue extraction to secure your initial answers, and embrace the blood draws for the long-term watch. Knowing exactly which diagnostic tool belongs in which phase puts you in control, transforming a terrifying medical gauntlet into a clearly navigated journey toward recovery.